I welcome everybody to this webinar on World Population Day on contraceptive updates. We are really happy to have some stalwarts talking on very day-to-day topics, very interesting and informative topics that we have lined up, which will be followed by a video and skit presentation by Family Welfare Committee FOGSI. And these presentations are going to be judged by eminent judges. Wishing you all a great learning experience for today. We start the webinar with a prayer song.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya Deepa Jyotir Namostute. Deepa Jyotir Namostute. Deepa Jyotir Parabrahma. Deepa Jyotir Janardana. Deepa Jyotir Parabrahma. Deepa Jyotir Janardana. Deepo hartu me papam. Sandhya Deepa Namostute. O Deepa Brahma Rupastham. Jyotisha Prabhuravyayah. O Deepa Brahma Rupastham. Jyotisha Prabhuravyayah. Arogyam dehi putrasya. Matim swachham hi me sada. Raverastam samarabhya. Yavat suryodayo bhavet. Raverastam samarabhya. Yavat suryodayo bhavet. Yasya tishte gruhe deepa. Tasya nasti daridrata. Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya Deepa Jyotir Namostute. Deepa Jyotir Namostute. Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada.
Is the Canada PR.
I now request our President in charge, Dr. Malti Prasad, to give a welcome note.
Good afternoon, everyone. It's my pleasure to welcome one and all for this contraceptive update on the event of the World Population Day. We all know that World Population Day is being celebrated on the 11th of July every year. The main purpose of this day is to draw attention towards the increasing explosion of the population. And we all know India stands second after China in our population. So the World Population Day is observed with the goal of highlighting the difficulties created by overpopulation. So this CME is to raise awareness about the paradigm shift in contraceptive methods available today. So we have real eminent speakers who are stalwarts in their own field. The first topic is going to be a combined OC pills tailoring to every woman. That is, every woman requires a different contraceptive based on her age and other risk factors. We have Dr. Sheila Mane who will chair the session. She's a Professor OBGYN KCGH Bangalore. And we have a very eminent speaker, Dr. Shobha Gudi, who's a chairperson of Family Welfare Committee FOGSI, who is going to talk on combined OC pills. The second topic is going to be a long-acting reversible contraception. Dr. TV Chitra, president of Coimbatore OG Society, will chair the session. And our own member, Dr. Shanti ma'am, who was my teacher during post-graduation, who's a past president of OXI, is going to talk on this particular topic. I understand that she has a lot of new information to give us so that it becomes easy to choose the contraceptive methods. The third topic is going to be an update on tubal sterilization chaired by Dr. Radha Madhavi, who's the president of the Tirunnamalai OG Society, and the speaker is Dr. Atul, who's a vice president for OXI 2021. So this very short introduction, I will not waste much of your time. I hand over the proceedings to Dr. Deepa, who will conduct and moderate the sessions. Thank you, Deepa.
Thank you, Malati. At the outset, I'd like to thank ICOG for granting one ICOG credit point for all the delegates who log in for this meeting. You will get an email at the end of either at the end of the session or later on from our society, crediting the ICOG point for you. So kindly log in and with your email ID, with your correct email ID and not the mobile display. Kindly log in with your name and correct email ID so that we can send the ICOG certificates to you. Thank you. And without wasting much time, we go on to the scientific session. I now take pleasure in inviting our first chairperson for the day, Dr. Sheila V. Mane. Madam is a renowned obstetrician and gynecologist with a lot of great credentials. She's a senior consultant obstetrician and gynecologist at Anugraha Nursing Home, Bangalore. She has a lot of services in FOGSI to her credit. She has conducted AICOG 2003 and 2019. She has been the Vice President FOGSI in 2014. She's been the Chairperson of Safe Motherhood Committee FOGSI 2008 to 2011. She's a National Coordinator of PPH workshops, ICOG Governing Council member, and she has participated in a lot of obstetric emergency care training programs across the country. She's won a lot of prizes and awards, to name a few: Best Committee Report Presentation on Safe Motherhood, Best Society Maru Hansotia Award in Safe Motherhood, President's Trophy as Best Society and Bangalore Society Secretary, Dr. D.K. Trank Trophy for Best Community Services as BSOG President, etc. And Madam is famously known as the PPH Lady of India. She has done extensive exemplary work in the field of PPH. She has conducted over 100 PPH workshops all over. She has done Helping Mothers Survive workshops all over India in 2013. Apart from AICOG, she has also conducted Dakshin. She has also conducted Yuva Foxy, etc. I can go on and on, Madam. It is indeed a pleasure and an honor to have an eminent person like you for chairing the first session today. Please welcome and take over the floor, ma'am.
Yeah. Let's stop sharing.
Can you stop sharing?
Yeah. Thank you, Dr. Malati and Dr. Deepa, for this opportunity. Okay. And I mean, after looking at you, I feel as if I'm in Trichy, and there are so many fond memories of Trichy. You know, so many programs I have attended there, and such a beautiful city and a clean city, I must say. Okay. I think Trichy Society has done lot of work on adolescent health as well as the other aspects also, and won many prizes even at FOGSI. So thank you for this invitation, and it's my pleasure to introduce none other than Dr. Shobha Gudi. I think I must say that she's like my younger sister and a close friend. Okay, she's like my younger sister, and we work together on many aspects in FOGSI as well as wherever we go for academics. And I'm happy to see that Dr. Shobha is doing so much of work as a chairperson, and which she wants to do, you know, and she was so particular to become a chairperson of particularly this committee that she had to really wait for many years to contest for this post, but she wanted to take it up. That shows her passion. And you know, recently we had a World Population Day, and she has taken a stand to really meet the unmet need of this family planning in our country. She's again a MD DNB and FICOG and CNP. She's a professor and HOD at St. Philomena's Hospital, a postgraduate teacher, a very popular postgraduate teacher, I must say. And currently she is the chairperson of Family Welfare Committee. She was the president of BSOG in 2018 and 19. She's an assessor for Government of India Project Laksha, board member of Family Planning Association of India, peer reviewer of Jogi, and governing council member of ICOG 2021 and 2022, and EC member of a Karnataka Association of Obstetrician and Gynecologists. And together we have edited a book that is Obstetric Hemorrhage, and she's also an author of FOGSI Focus, and she has participated in GCPR of FOGSIs and publications. She has many to her credit, national as well as international. But main thing is, her passion is now the Family Welfare Committee and the work she wants to do to really to see to it that we meet the unmet need. So over to you, Dr. Shobha.
Thank you so much, Sheila. That was a very, very generous and kind introduction. And really what you said is very true. I too look upon you as, you know, my own. And I have always cherished your friendship and your mentorship. So that is kind of very mutual. I will now share my screen, but even as I do so, I'm very grateful to Trichy Society, to Deepa Mukhundhan, and the president in charge, Dr. Malati. And I am very grateful that seniors like Dr. Ramani, who has been the vice president for me in the year just gone by in Foxy, and also Dr. Shanti Gunasingh, who is a very good friend and a co-worker in the committee, Dr. Radha Madhavi, and I can see so many eminent personalities from Trichy. And as Sheila rightly pointed out, Trichy has a very rich history of conferencing and knowledge dissemination, and we have always been very thrilled to participate and to take the darshan of the deity also there. And Deepa, I am very grateful to you that you brought in this program in the middle of our ongoing activities for population stabilization fortnight, and also that you have graciously accommodated the videos. We were hoping for more participation, but nevertheless, I feel we should cherish whoever has come forward and has participated for this noble cause. Well, I think the conversation around contraception and population stabilization always begins with how many we are, how numerous we are, and when will we stop increasing in number. But believe me, it is a beautiful thing that we account for more than 72,000 births each day. It is really lovely that so many Indians are being born, but at the same time, we need to match our resources. And for that reason, if we could have a reduction in the unmet need, and actually speaking, it kind of, if you have a client-centric philosophy for family planning, then it is very easy to see that when there are more than required number of pregnancies and unwanted pregnancies, then it is the woman who is at the center of some kind of abuse, because denial of family planning services also accounts for gender-based abuse. So women with unmet need are those who are fecund and sexually active but are not using any method of contraception and report not wanting any children or wanting to delay the birth of their next child. And why is it so that there is an unmet need of about 20% even today? Maybe it has marginally decreased to about 17 to 18%, but we still have about 12 to 13% of unmet need for the limiting method, and about 5 to 7% for the spacing method. So today we no longer call it the permanent or the temporary, but we term them as limiting and spacing. Now, why is it? Why is it is there? It may be because we are not matching up as service providers in alerting our women that unless they have a very regular ongoing method of contraception, they are at risk for an unintended pregnancy, perhaps for an unsafe abortion, perhaps for a high risk pregnancy, perhaps for a miscarriage or reproductive wastage, and maybe a high risk delivery, and probably so there is some chance that there can be a morbidity and mortality resulting from it, especially in the pandemic when we need to focus all our resources on the management of the pandemic. So today, I think let me center towards one tiny part of our discussion, and that is the choosing the right combined OC pill. Well, this is only part of it. Let us also look at choosing the right contraception for the right woman in general. So I will be kind of bringing it in very comprehensively. I'll try to be very crisp on the research data, and I will try to keep your mind engaged, because indeed contraception can run into dryness and mundane information, but I'll try to keep it very engaging. Now, unintended pregnancies, let us believe that there are about 80 lakh pregnancies unintended in India annually, out of the 26-27 million pregnancies births which take place. Actually, the total pregnancies, if they are 48 million, then this many are unintended. And I have already spoken about the consequences, and they are a strong indicator of failure of service provision. And this is a very beautiful effectiveness chart which I have time and again showed. And this is only to re-emphasize that every practitioner can have a laminated chart like this on their consultation under the glass top table, and need not look at it as an embarrassing factor, because quite a bit of display of the reproductive organs are there, but rather encourage the woman in front of us to look at this arrow and realize and understand the left hand side arrow, and understand what are the most effective methods, and tell her the dangers of using methods like consistently using condoms necessary to prevent infection, but to be very, very safe from pregnancy, she has to opt for the hormonal contraceptives or for the LARC method or for the limiting method when she has completed her family. If you look at the trends in India, then I think we need to understand that 1/3 of women do use a contraceptive method in the reproductive age group. And the majority of these women do use a modern contraceptive method. But when we say modern contraceptive method, it also includes the sterilization, and majority of these will be sterilization. The contraception prevalence rate is around 50%, maybe. I would rather think that it is around 50 and not more, not 54%, because at any given point of time, we find that almost 50% of women are not using contraceptives. Definitely not using. So this is again the breakup of that, which I already have spoken about. I have put this pie chart very specifically to tell you that there are, in these rainbow colors that you see here, and there are very wonderful methods which are being underutilized. So let us look at the PPI UCD. Can you see that 1.5%, that is so abysmally low. If you look at this pink, the injectables, it's very less. It should be much more than that. If you look at the pill, again, it is only 1.5%, which is so very low. And the male sterilization, you need not say. Pill is around 4%. It should be actually 25% as it is across the globe. And I think the most discouraging or the depressing factor is the male sterilization. In spite of it being such a less invasive procedure, or almost a non-invasive procedure, it is 0.3%. And that needs to be improved as well. So when we look at counseling, women should understand that birth at less than 24 months interval is ideal. First birth should not be too early after marriage, and unintended pregnancies should be prevented at all times. The data show that the level of awareness of contraception may be higher, but the acceptance is lower. And the family factors and the attitude of families towards contraception are responsible to a great extent. Women who deliver girl children will be less keen to practice child spacing, because their worth is measured by the fact when she can, and how early she can provide a male offspring to the family. Partner opposes usually and promotes non-usage of contraception, and in-laws also do not allow birth spacing for some fear of losing the fertility potential. And today, I think the concept needs to change into an integrated care services, which the committee has been emphasizing for the past 2 years, that we need to bring in the concept of integrated care. So any woman who, with whom we have the opportunity to be in contact, whether she's pregnancy, whether she's in labor, in the postnatal ward, or in the immunization, or even if she has come for HIV services, etc., we need to promote contraception at that time. I must tell you at this juncture that the government TRG group of family planning today has is coming up with a very extensive document of counseling on RMNCH+8, and that is going to percolate through our services very, very soon, and that will help us with a better direction in counseling. The impact of structured counseling has really been highly conducive to acceptance in the observational studies which have been so far done. And one such study was by Dr. Nozer Sherier and a team in India in 2014, and it did see publication also, and they found that whenever there is counseling, there is an increase in acceptance of almost all methods, as we can see. And then when they do accept the methods after counseling, there is a kind of a slight trend towards higher acceptance of COCs as regards in comparison to other methods, because our counseling will always highlight the benefits of any contraceptive method. So in an overview, worldwide about 100 million women use COCs, and actually the COC was discovered serendipitously when by accident, when a Puerto Rican in Puerto Rico, when a progesterone product was contaminated with mestranol in the first human trial, and it was found that it was with a synthetic estrogen. When you combine a progesterone, it becomes a highly effective contraceptive, and it also gives a better cycle control. And ethinyl estradiol becomes a very stable molecule because of the addition of ethinyl group at 17 position, and therefore it has got a higher kind of efficacy as a combination drug, as part of combination than mestranol. So we often wonder why that one is the one which is chosen. The major side effect and the fear, of course, is the risk of thrombosis. In the mind of every practitioner, this will be foremost in their mind. And the dose of estrogen is a critical issue. And when we have been reducing the dosage of ethinyl estradiol, then it has resulted in, the decrease in the incidence of thrombosis. When we reduce the estrogen dose, the 20 microgram provides high efficacy and acceptable bleeding patterns with the same kind of failure of pregnancy and failure of the method and resulting in pregnancy, and therefore it is very suitable. When we look at the progesterone component, it has undergone an evolution over the decades as the first, second, third generation, and the fourth generation. The fourth generation is the drospirenone, the famous anti-androgen, which is today used a great deal by all of us. And the third generation also has a very, very strong place, desogestrel, because it has got a reduced potential for androgenic, estrogenic, and glucocorticoid effects. So the minimal side effects are seen with desogestrel is with what we have come to believe. The fourth generation of progestins, to be understood well by all of us, it is important. And the first generation was the 17-OH, the second was the gonanes derived from testosterone like levonorgestrel, the third one is desogestrel, gestodine, norgestimate, and the fourth generation are the dynagest and the drospirenone. And today we have very good results with dynagest as well. This is a table which we'll just need to touch upon before we go ahead. And let us look at the two commonly used ones by us, the desogestrel and the drospirenone. And it is very evident the drospirenone has an anti-estrogenic as well as anti-androgenic activity, also anti-mineralocorticoid. Desogestrel may not have such a versatile profile of activity, but it does have very, very minimal androgenic activity and is more suitable than the levonorgestrel preparations which were available earlier. The receptor binding efficacy is also comparable in all these, and the selectivity index for progesterone receptors is highest in desogestrel is what is believed. The benefits of COCs, of course, apart from protecting from pregnancy, it also protects from cancer, up to 50% reduction in endometrial and ovarian cancer, decrease in PID, in ectopic pregnancies, in anemia, in formation of ovarian cysts, of course, better cycle management, reduced menstrual symptoms. There is a benefit in hirsute women and women with acne, and of course, the PCOS symptoms mitigation is a very added benefit. So also the symptoms of endometriosis become reduced, and there is a lesser impact, lesser incidence of symptomatic PID in such women. So making the right choice will essentially involve our understanding of the MEC criteria, the category 1, 2, 3, and 4. And as we go ahead, I think all of us know these. I shall not waste time in that, but I would certainly like to show you this. This is the retirect now, and you can see quite a few greens here and a few reds, and some oranges, and quite a few light greens, and you can see that these are the categories. Now this is also an excellent sheet to have with you, even better than the wheel, because you need not look at the wheel and turn it, etc., and you could immediately see what is suitable for whom. And let us believe, I keep on repeating this, that MEC criteria are regulatory and not restrictive. So in any given woman with any kind of severity of any medical disorder, there is always some contraceptive that you are able to prescribe her or to advise and protect her from an unwanted pregnancy. The greens are far more in number than the reds, is the message I wanted to give here. Now this is another for clinicians for practice recommendations for contraceptive use. And this is from CDC ACOG criteria, US select practice recommendations for contraceptive use, and fairly recent, just 4 or 5 years old. And this categorizes the recommended examinations for tests which are necessary prior to initiation in women presumed to be healthy. In women presumed to be healthy, I shall repeat. So remember that usually contraceptions are given for women who are healthy or for women with medical disorders which are under reasonable control, and therefore it makes them suitable for contraceptives. Now these tests or examinations are classified as A, B, and C. A are the essential mandatory in all circumstances for safe and effective use. B contribute substantially to safe and effective use, but implementation may be considered within public health or cervix context. And then class C is does not contribute substantially to safe and effective use, so therefore need not be done. So what is encouraging here is you can see that very few of the tests written on the side are A, very few, only 3 I can see in the entire list, almost no Bs and a lot of Cs. And that indicates that these lab tests, majority of them, and these parameters and assessment and these clinical examinations are actually not contributing to substantially to safe and effective use. Well, I wanted to give the message from this slide, from this table, is that contraception is the most, friendliest type of therapy or preventing measure or prescription which can be delivered across the teleconsultation platform, across a virtual platform. So that is the message I wanted to give, that because this is the era of video consultation, teleconsultation, and here we need to be very, very minimalistic on the tests which we advise, and this chart will definitely help you, and again a tool to be kept handy for clinicians, or at least in the clinic, the family planning clinic, where the counselor also can look at this. So let us look at the A for which method and which examination. So if you have a blood pressure assessment, it's not required for copper T insertion or implant or injectable or POP or condom in a woman who is not a known hypertensive. Please remember that. I've already told in the heading, in women presumed to be healthy. So in a woman who is not a known hypertensive, BP measurement is not required except when you prescribe a CHC, a combined hormonal contraceptive. So also a bimanual examination and cervical inspection is not required for any of the contraceptives, especially except for in 2 situations. One is the copper IUD and the LNG IUD, which is mandatory, of course, anyway that is required. And whenever a diaphragm or a cervical cap is used as a female barrier. None of the others, the lab test, you can see sugar estimations, any of the blood parameters not required. Even a PAP is not required. Even an STI screening is not required. Of course, it can be advised as a add-on, but it is not a mandatory prerequisite for prescription of contraceptives. So this is the message I wanted to give. And I think I have done almost half the job by having spoken this much. Right contraceptive for every woman can be chosen at any age, and COCs especially can be given in any age group. I don't think I should spend more time on this, and this is something I have spoken again. Already spoken. It it is of immense benefit to women with hyperandrogenism and the resultant symptoms like in PCOS. And of course, we all know how it acts. And of course, this is again what I have spoken, that there are many statutory authorities which say that COCs benefit endometriosis, adenomyosis, and rheumatoid arthritis, and may improve bone mineral density and reduce fracture in premenopausal women. That is why there is a concept of using them as contraceptive method during the window of opportunity in the perimenopausal age group, and reduction in cancer. I have already spoken, and incidentally, the benefit of reduction continues beyond the use of COC, which they are used for 5 to 10 years. Again, I have spoken about its benefit on PCOS and who can and cannot use. So we have seen that almost all women after childbirth, after 6 months of breastfeeding, after abortion, miscarriages, even those who smoke a few cigarettes, and even those who are above 40 years of age, anemic, etc., even those who are living with HIV, all of them can use nulliparous women. But avoid unnecessary procedures. They can begin using. Again, I have spoken about all this. No pregnancy test, breast examination, pap smear, or blood test is needed. The risk of venous thromboembolism, I think I'll just touch upon this before I go to the next slide, not the rest of the slide. 30 in 10,000, the risk of VTE in normal pregnancies, 30 in 10,000. In COC users, where pregnancy is avoided, it is much less, 9.1 in 10,000. Now this compares to 4 to 5 in 10,000 in the never users of COCs in the general population of women, non-pregnant women. So it does double the risk to the never users, but then it is still very, 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 very rare. And this possibility can be excluded by taking a careful history for the mother, and also for the woman, sorry, and also it is anyway much less than pregnancy, 30 to 35% less than pregnancy. Okay, so the risk-benefit perspective of COC usage goes in favor of benefit in most instances. So I think the rates of hysterectomies come down when you use hormonal contraception. The quality of life is better for women, etc. So the widely used ultra low dose COCs is a good friend for all of us, and the desogestrel with ethanyl estradiol as well as drospirenone with ethanyl estradiol are good drugs to be used. And the key takeaways on ultra low dose pills from comparative trials tell us that 20 micrograms of ethanyl estradiol with desogestrel is very, very good method for contraception, better cycle control, improvement in quality of life. And so also is drospirenone. The only thing is drospirenone has slightly higher incidence of milder side effects. These are essentially studies which have been done on quality of life, and you can see the various outcomes which have been compared, and all of them say that there's significant improvement in quality of life with COC. The cycle control and tolerability, the key takeaway is again that desogestrel containing drugs better cycle control, less acne. And when compared to drospirenone, you can see the number of studies, and I think we all understand today, there is clear understanding that there is immense research which has happened in contraception. Perhaps after cancer drugs, the most research has happened in contraception, much more than the fertility enhancing drugs. And we must stand by that evidence and believe that what we are doing is right for the woman. Very, very low Pearl index in both the drugs, both the drug combinations, and this is the cycle control, body weight, no impact on the body weight, no increased weight at all, and user satisfaction is also high. So high user satisfaction, no impact on body weight. Cochrane data also tremendously supports the use of low dose progesterone. That means essentially low dose progesterone and smaller dose of estrogen like 20 micrograms, and 30 trials of almost 14,000 participants. So I just wanted to bring home the evidence so that you are more and more convinced to write the prescriptions. They're less likely to discontinue if they are using the third generation progestogens. And the only thing is drospirenone, slightly higher complaints of breast tenderness and nausea, but of course that can be. The missing tablet guideline also has simplified today that tablet taking must never be discontinued for longer than 7 days, and 7 days of uninterrupted tablet taking is required to get an adequate suppression of the pituitary ovarian axis. And in women who have missed up to 2 tablets, there is nothing to worry. But if they miss 3 or more, then they need to continue the strip. Nevertheless, have an added method for the next 7 days or so if they are in week 1 or 2, but not necessary if they are in week 3. So in summary, for this, the health benefits outweigh the risks. It has got low androgenicity, the desogestrel containing drug. Of course, drospirenone is anti-androgenic, and remaining is what I have already spoken. 150 desogestrel, 20 microgram ethinyl estradiol is highly effective, and they are very well tolerated. When following this disclaimer, I just wanted to bring in few case reports before I conclude. All women deserve access to care that can save their lives, is what Christy Turlington said. She was the champion for women's emancipation, and she was a model turned journalist and philanthropist. And I think contraception prescription in the pandemic and even otherwise can save lives. These are the case scenarios which I thought, we will just go through very, very quickly. 22-year-old software techie recently delivered by cesarean section has developed breast engorgement. Probably LAM method may not help her if she is too involved in her work, and she needs to be given the entire basket of choice. 37-year-old Farah has been referred for sterilization, but we find on examination she is hypertensive and dyslipidemic and has got a bulky uterus with restricted mobility. And can we perform a sterilization? Yes, we can. In the ACDS, we can criteria for MEC criteria for sterilization, we can opt for the S, the special category. She can be performed in a tertiary care center with good counseling. And if we encounter a lot of adhesions, we can also preemptively counsel them for a LARC method during the procedure. And also possible that in this case, an NSV can be recommended to the male partner, to the spouse, before we take her up. A 31-year-old married paravan living one 8 months back requests MTP, and then should we not counsel for contraception? As of course we should. And today there is very good understanding that after the abortion, immediately we can offer her the basket of choice, even as we give her the abortion pills. Immediately we can counsel for contraception, both for first and second trimester. There is a role for post-abortal IUCD insertion in both, and that is as per training and guidelines. 33-year-old woman with a 5-year cesarean section, 5-year child delivered by cesarean section. She does not want a surgical procedure, does not want an IUCD, but has got heard about a monthly ring. And can we help her? Yes, vaginal ring is available in some parts of the country. And when a woman has already a predilection for a method, she should be encouraged to explore the possibility of using that. And we should tell her the pros and cons, and we can still offer her the basket and tell her other methods, but then she can opt for what she has chosen. 39-year-old obese diabetic on OHA with heavy bleeding, diagnosed as AUB, also wants contraception. Of course, we can offer her the LNG Iuds, the progesterones, etc., even low dose oral contraceptive pills, because NICE guideline says that the AUBE and AUBO, the first line treatment can be low dose oral contraceptive pills, provided we have ruled out atypical hyperplasia. And non-steroidal contraceptives also can be used in women where AUB has resolved, and endometrial ablation sometimes can be offered. But the contraceptive methods should be amongst the hormonal contraception for AUB. Are hormonal contraceptives contraindicated in an obese diabetic of 39 years is a question. Well, they are not. And any medical disorder where contraception is contemplated, the first priority is to control the disease to the optimal standard. In a well controlled diabetic, these are not contraindicated, and that is what I wanted to emphasize on. A woman who travels a lot and is a very high profile career oriented person and wants to have fewer periods also, and in these women we can she also suffers from PMS, we can give her the long courses of COCs which are available, like extended cycle regimes and continuous cycle regimes like seasonal, etc. Now here is an adolescent. I have put it as 19 here deliberately because so many girls still come under 18, but I think they are all with high risk behavior, socially insecure. They have to be given dual method of contraception. And please beware of POXO Act here, because if they are less than 18, or if the partner is less than 18, it is a criminal offense, even though it is consensual sex. And we not only should desist from giving a prescription of contraception, but we must also understand that it is our responsibility to inform the nearest law authority, or at least put a mail to the nearest law authority that in your knowledge such a thing is happening. Not that we should not be counseling for contraception. We can counsel them and tell them that sexual debut is legal in our country only after 18, and also that they should be aware of safe sex practices and all contraceptive methods. The Primy comes to you for routine ANC. Should we talk contraception? Yes, we should. Yes, we should. And tell about postpartum contraception. This is the WHO postpartum contraception. So many methods are safe for them. And this is the checklist for PPIUCD. And if the woman passes through this checklist, eminently she can be given. So this is postpartum contraception in the MEC criteria. And you can see that COCs are difficult in the breastfeeding women early after delivery, but after 6 weeks or so they are okay. And if they are breastfeeding and very early after delivery, I think you can delay the injectable also up to some time. Now this what I have shown here has been revised recently, and breastfeeding women less than 3 weeks, only for 3 weeks we need to desist from prescribing POPs. After that they can be given, so it's not category 3. And so also implant has been revised now. So I have put this up only to tell you, of course the revisionary thing I have not written here, but it has got revised to MEC category 2. Even implant is MEC category 2. So a woman who has delivered in the hospital is about to go home can be given a prescription, can be fitted with a PPIUCD or an LNG-Iuds with MEC category 2. She can be given an implant insertion with MEC category 2 where benefit outweighs the risk. She can be given a prescription of Centroman, of POP, and told about barriers. And these are the type of methods which are available for them. Smokers, if they are smoking a lot, then they cannot take estrogen containing, otherwise it is okay. All right, women who are on anti-tubercular drugs, we all know that we need to be very careful about giving them COCs, and so other LARC methods or limiting methods are suitable for them. If they have suffered from DVT in the past, it's important to take a very good history to find out whether the process is ongoing, and then see whether they can be given a suitable contraceptive method, because pregnancy is all the more risky for them, and it's better that they plan it very, very well. And you can see estrogen containing is contraindicated. In a current DVT, the other hormones are also category 3, but the copper IUD is fine. Even LNG-Iuds in an active thrombosis we don't give, but when there is a family history or when there is an immobilization, estrogen containing is contraindicated, but the others are okay. So I think I shall now kind of be a little quick, because I think my time is running out. Fibroids, unless they're distorting the cavity, there's no contraindication. Neither is there for endometriosis. They can be given any contraceptive. Whenever there is cervical disease, cervical cancer, the copperty, if it is already inserted and we have diagnosed a cervical cancer, there's no need to jump and remove it. We can allow her to continue till such time that the treatment comes in place. Afterwards, probably she will not require, the contraception. But to initiate, it is category 4. So that is all right, that we understand. So also for endometrial cancer. Because these women may be waiting for their therapy and they should not conceive. Some of them are young and in reproductive age group. Ovarian cancer as well. Ovarian cancer as well. Ovarian cancer as well. That initiation is category 3, but continuation is category 2. Okay. All right then. So, okay. Hypertension. Only one word about hypertension. I'll not take time. Hypertension is probably the only disease where, absolutely we cannot give estrogen at all, whatever the control and whatever the accompaniment. If the only exception is if she has had hypertension only during pregnancy and after that she has been normotensive, well, she can be given COCs. The other method which should not be preferred in women with hypertension is the injectable. But if they are well controlled, then injectables can also be used with MEC category 2. Of course, they need more surveillance to have a watch on the underlying disease. I think this is for epilepsy, and the newer anti-epileptic drugs like lamotrigine and levetiracetam. Even the POPs are category 1, whereas estrogen containing are category 3 for all of them. Okay, about epilepsy, we have spoken already that if there is an aura and there is a problem with prescribing them with COC, most of you know that. And without aura, if they are non-migrainous, then probably it is all right. Initiation without aura, epilepsy without aura, initiation is fine. But if a woman is on COC and she develops suddenly epilepsy, if she manifests with migraine without aura, then I think we must stop the COC and go ahead with other methods. So these are the nuances of prescription of contraception, and the MEC criteria helps us eminently, very, very well. This is for SLE, and they are having concomitant APLA, and you cannot give them COCs or POPs. Severe thrombocytopenia, again, COCs and injectables cannot be given, obviously. Even implant insertion, there is no guidance, but I wouldn't want to insert an implant when there's severe thrombocytopenia. When they are on immunosuppressive treatment, surprisingly, they are all fine. With heart disease, I think I'll end with these 2 slides. It's important to know about heart disease because quite a few women with heart disease today are, going through pregnancies. And ischemic heart disease, estrogen-containing drugs are a problem. If they develop IHD during pregnancy, during contraception use, if they develop ischemic heart disease, which is not unknown today, many young women are having angina and myocardial infarction. So in them, the continuation of hormonal contraception is a problem. But initiation, surprisingly, is quite okay. Is category 1 and 2. But continuation is a problem because it means that they have been having problems while taking the hormones. But even then, I think most of us would prefer a local method and rather than giving them hormones. But I think implants are quite safe in them to initiate. That is what is the current evidence says. Let us understand that low dose pills in the perimenopause women, pill is pretty safe. Some women are dangerous, and quite a few women are suitable for pill. Only some women are dangerous. We need to screen them out, and LNG Iuds is a lot of benefit for older women because we can continue it as part of the menopausal hormonal therapy as the progesterone component. So family planning alone could bring more benefits to more people at less cost than any other single technology now available to the human race. I think we need to, integrate this thought into the most superficial layer of our conscience and think about, talk about, and prescribe contraception on every possible occasion. We need to understand that MEC is regulatory and it is not restrictive. It is not restrictive. We can always give some contraceptive option to any of our women who need it. Thank you so very much, and I hope I have not exceeded my time too much. Thanks a lot.
Ma, I connected earphones to you.
Ma'am, I think Dr. Sheila ma'am has excused herself. It was a wonderful talk, ma'am. It was very, very informative. I think you have covered almost all aspects of how to choose a contraception. I'm glad I invited you for this talk because every day we are seeing patients with migraine, with epilepsy, hypertension, diabetes, and there on one side you have population expulsion. On one side you also have people who don't want to go ahead with more than one baby. That's becoming very common nowadays.
Yeah.
And people embarking on pregnancy very late in their career. So it's a very extensive and very well spoken topic, ma'am. Congratulations.
So, congratulations, Shobha. Very extensively covered.
Thank you,
Yeah.
Sheila.
You were
Thanks
just
a
getting
lot.
ready for another webinar. Left in
Thank you.
between and came
Thanks
back.
for giving us your time, Sheila,
No,
today.
no problem. Every day we are, I think as Deepa said, no, it's very important because we have people with only 1 or 2 kids in, particularly in bigger cities and in urban Europe. Okay. So starting their pregnancy is very late. So it's very important, and the users are, the number is still need to be picked up in India, and I think for that all of us have to really work hard. It is just like MHT, like how in menopause, we have to really promote that the same way. I think here also we have to really push people for the COC's use, I think. Thank you, Shobha, and congratulations. Okay. And thank you.
Thank you so much, Sheila ma'am. Thank you for your time. I think madam has to go for another webinar. So thank you so much for your inputs and for being with us today, Sheila ma'am. I now, any questions? I think we can take questions from the audience. A lot of people have appreciated the talk. It was a wonderful talk. Audience can post their questions in the chat box, and we can take the questions after each session. Madam, we move on to the, right now I think there are no questions, so we move on to the next session. Dr. Shobha ma'am will be with us for quite some time, for the entire evening today. So I think she can also take questions at the end of the meeting. I'm sure there will be questions. Thank you, ma'am. Thank you. So with pleasure, I now invite our next chairperson, Dr. Chitra, Dr. TV Chitra. Can I have Chitra ma'am's? Yeah. Dr. TV Chitra is a professor and unit chief of obstetrics and gynecology at the PSG Institute of Medical Sciences, Coimbatore. She is the current president of Kovai Obstetric and Gynecological Society, scientific committee member of UFOXI 2019, and a member of IUGA and ICOG. She has special interest in urogynecology and high-risk pregnancy. She has been honored by Teaching Excellence Award 2015 by the institution. She's been a great postgraduate teacher and examiner. She's been a faculty in many national and international conferences. And also she has a lot of publications in national and international indexed journals. So welcome, Dr. TV Chitra. Welcome to Trichy. Kindly take chair for the next session. Thank you.
And it's indeed my proud privilege to introduce Dr. Shanti Singh ma'am. In fact, we've been associated with Shanti ma'am for quite some years. We have our, every year we have a PG refresher courses, and Shanti ma'am is always an invited faculty. The first time we had madam was when we did the GDM. It was such a wonderful prestige, still alive in my memory. I'm so clear and crisp we were. From that time, madam has been there for many of our programs. So, madam has held one of the most prestigious posts at any government medical teacher would like to have, and that has been the director of IOG. In fact, that is a very, very prestigious post. Everybody looks upon with great awe and administration. So Madam was a former director and superintendent of IOG. She was a former HOD of Kilpack Medical College. And Madam was also the past president of Oxy. And Madam is a master trainer for BMOC, EMOC, and that has helped to reduce the maternal mortality in our country to a great extent. Madam is also the recipient of AL Mudlia Travelship 1993. She's an invited speaker in many national and state level conferences. And I'm sure if you see in many of the postgraduate teachers, Madam is always there. Be Tamil Nadu Society, which is doing it, or Kerala, anywhere, Madam is always there. So over to Madam to talk about this most important topic, which is LARC. And I'm sure there are a variety of contraceptives that we have. Everything has its own advantages and disadvantages. So let us hear from Madam what she has to tell us about long-acting reversible contraceptives. Over to you, Madam.
Good evening to one and all. Good evening to one and all. I thank Dr. Malati and Dr. Deepa for having given me an opportunity to speak in Trichy in this program. And I also thank Dr. Chitra for her very kind introduction. And the topic given to me is LARC, L-A-R-C. So what is LARC? So LARC is defined as contraceptive methods that require administration less than once per cycle or month. So as per ACOG guideline 2017, they talk only about intra-uterine devices, copper-containing IUD, hormonal IUD, and birth control implants. Although they have injection Depo-Provera freely available, both intramuscular and subcutaneous, it is not taken into consideration into LARC. So many papers have come out from US, but they do not talk about Depo-Provera for LARC. For other things they use for non-contraceptive benefits. And then NICE guidelines 2017 talks about intrauterine devices, both copper and progesterone only intrauterine systems, then progesterone only subdermal implants, and progestogen only injectable contraceptives. This is the data from National Family Health Survey 4, which shows us about the contraceptive methods what Indian women use, especially currently married women aged 15 to 49. So it is really sad to note that 47% of our women do not use any method. So there is really urgent need to promote contraception among these patients. And it is also, we have to note this point that 36% of women follow contraception by taking recourse to the permanent method, that is female sterilization. So now, as per NFHS 4, the mean age of female sterilization is about 24. They are quite young, and nearly 7% of women who undergo female sterilization, they have some regret. They really regret their decision, and sometimes they can lose their babies, or in the present situation, they can even remarry. So all these patients find it very difficult when they take recourse to female sterilization. So it's very, very important to push a LARC forward so that some method of contraception is given to them. And also, even if they are not very compliant, it doesn't need much effort on their part. And also, it is not a permanent one. And here, as per this NFHS 4 data, we note that 24% of contraception is offered by private health sector, NGO, hospital or clinic. So it's not only public health sector, as private health sector, whereas doctors in private health sector also, we have to really take contraception seriously. So why LARC? This is the most effective reversible method of contraception. High rates of user satisfaction, do not require daily adherence. That is the most important thing. So compliance is not at all needed. Require fewer visits to health service. The pill over 12 months. So in the long run, it is really very cost effective, suitable for women of all ages, and do not affect fertility after removal. This is as per ACOG 2016. But then the Depo-Provera, the injectable, that when it is used, that can fertility can return only at a later date after a period of about 7 to 12 months. This Dr. Shobha Gudi also showed. So the most effective contraceptives are sterilization, which is a permanent method, and intrauterine device and implant. In all these three, the pregnancy rate is less than 1 pregnancy per 100 women. So implant and IUD come under LAR. We also have the injection where it is about 6 to 9 pregnancies per 100 women. And the woman needs to come only once in 3 months. So that is really much better than using the tablets daily. So coming to intrauterine device. This is the most commonly used LARC method worldwide, and it has been steadily increasing, used by 23% of female contraceptive users. As had been told earlier, failure rate is comparable with tubal sterilization. So indeed, it is a first-line alternative to surgical sterilization. So it is indeed, our women need not go in for surgical sterilization at all. Every 10 years, they can change their IUD, and then probably menopause, they will soon enter into menopause. So maximum probably they will need insertion twice or thrice. So we also know about the type of various intrauterine devices. What is now available freely is Property 388. We used to have multi-load 375, but then now the availability is not that free. It used to be available even in government sector, but now it is not available in government sector. And so in private, it is essentially Property 250 and 375. We have the hormone releasing IUDs, where LNG IUD Mirena is present. We also have other ones like Emily, which are cheaper. So how do they act? Essentially by the foreign body effect induced by the plastic or metallic frame, and local changes due to the sterile inflammatory reaction and the production of cytotoxic peptides and activation of enzymes, which lead to inhibition of sperm motility. So who are the candidates for intrauterine device? Any client who desires one of the most effective method of contraception, but it should be a reversible contraception, and who wants or needs to avoid estrogen exposure. So both IUDs, both copper as well as levonorgestrel IUD will cater to this prerequisite. And if a woman needs to avoid hormonal exposure, any hormonal exposure, be it estrogen or progesterone, then copper IUDs can be used. So we all know about the T-shaped polyethylene frame with 380 millimeters squared of copper wire round. And now the 3 millimeter ball at the base of the stem, that decreases the risk of cervical perforation. It is radio opaque, and so if it is the threads are missed, then probably an X-ray will really help, and it is latex free. So what are the benefits of IUD? One-time motivation, that is the most important thing. So after that, even if she thinks over, she has to go to a provider to take it out, and does not interfere with sex. No medicine interacts with IUDs. No effect on amount or quality of breast milk. No hormonal exposure. 50% less likely to have ectopic pregnancy. But then, if pregnancy occurs, chance of ectopic is higher, nearly 30%. This is what is quoted in the literature, but so many times we see that many of them are intra-uterine too. But any pregnancy following COPD, we have to rule out ectopic, and its effect lasts for 10 years. And it has continued menstrual cyclicity. Our Indian women are very particular about having regular menses, so it caters to their needs. And rapid resumption of fertility following discontinuation, 70% become pregnant within 1 year of IUD removal. And the most important thing is it can be used as an emergency contraception if inserted within 120 hours of intercourse, less than 0.1% pregnancy rate. So any woman who approaches us for emergency contraception, instead of offering progesterone-only pills, it is ideal to offer IUD, copper IUD as emergency contraception. So it becomes as a definitive continuing contraception too. It has its own disadvantages. Earlier, so much used to be talked about pelvic inflammatory disease and the risk being higher in the first 20 days, 9.7 cases per 100 woman years. But then now we understand if IUD is inserted in an aseptic manner in an appropriate woman who doesn't have any infections, then probably this does not occur at all. And earlier we used to give doxycycline 200 milligram or azithromycin 500 milligram orally 1 hour before insertion. That reduces chances of infection. And this earlier in women who are at risk of developing infective endocarditis, COPD was a big no-no. But then now WHO recommends prophylactic antibiotics for patients at risk of infective endocarditis, amoxicillin 1 gram 1 hour before insertion. And there used to be a lot of talk about actinomyces colonization on the threads, but this does not warrant routine removal. Penicillin and tetracycline can be given. But ACOG says there is no need for antimicrobial treatment if asymptomatic. And the most important thing is with IUD in situ, all minor procedures can be done like endometrial biopsy, colposcopy, cervical ablation, excision, endocervical sampling. All these can be concurrently done. So what are the disadvantages? The big problem is the irregular vaginal bleeding, intermenstrual bleeding, which can be seen. And especially this is common in the first 3 months. So we have to counsel the patient very well. After that, usually it stops. The spotting really stops. But then they can develop heavy menstrual bleeding, which can be well treated by tranexamic acid and mefenamic acid. And the big problem is dysmenorrhea. Perforation is less than 1 in 1,000. And expulsion is due to 8% in first year. And they do not prevent STIs, especially in a high-risk woman. And trained personnel are needed for insertion. High initial cost in private sector. Insertion is painful, but can be tolerated. So probably NSAIDs can be routinely given if the woman is not allergic to it. Mefenamic acid 500 milligram 1 hour prior to insertion will really help. And the efficacy rate is very, very good, 0.5 to 0.8. And in India, as per ICMR, 76 to 89% of users in India continue IUD. Who really discontinue IUD are generally those who go and have it removed with other doctors. So as physicians, it is our bounden duty to counsel the patient about the need to continue, and if necessary, probably it can be removed. And as per US medical eligibility criteria, women less than 25 years, we have to replace every 10 years. Women 25 to 34 years, they can be left in place up to 12 years. And women more than 35 years, you can leave it until menopause if patient is happy and still requires contraception. And what about the timing of expulsion and timing of insertion? So post-placental, it can be inserted. That is within 10 minutes after delivery of the placenta. If it is really done properly and appropriately, the expulsion rate is about 0.5 to 12.5, 9.5 to 12.5. And immediate postpartum, that is after 10 minutes to 48 hours post-delivery, the expulsion rate increases. So soon after delivery of the placenta, if we insert post-placentally, the expulsion rate is less. And late postpartum, we all know that is after 48 hours up to 4 weeks. And as per Government of India guidelines, 48 hours to 6 weeks post-delivery, it is not recommended because of the increased risk of perforation and expulsion. An interval, it can be done after 4 weeks post-delivery as per WHO, and 6 weeks later by our Government of India. The expulsion rate is 3 to 13%, and it is quite safe. And post-menstrually, it should be inserted on day 4 or day 5 of periods. Post-abortally also, it can be inserted immediately, but the chances of expulsion are increased 5 to 10-fold. So how do we insert post-placentally the IUCD? So it's very important soon after delivery of the placenta, this multi-node, this property 380A, it should be held with the Kelly's forceps. So Kelly's forceps is a long forceps, about 35 centimeter long, and you catch hold of the right side of the horizontal step. So that is very, very important. And then the more, so many times expulsion is there because there is an angulation of the uterus from the cervical canal. So it's very important to put a hand on the abdomen, the left hand on the abdomen, and then nicely straighten it out after going up to the cervical canal, and then going up to the fundus and releasing the IUD, and then opening it well, and then coming out nicely on the lateral aspect. So we go directly inside, and then the left hand on the abdomen, and then which really corrects the angle. Then fundal placement is done, and after that we open it and then bring the Kelly's forceps laterally so that the thread is not pulled down. We do not trim the thread when post-placentally it is inserted. So we have finished the copper IUD, and coming to progesterone only intrauterine system. So it contains levonorgestrel. So this is a reservoir for levonorgestrel hormone, and these are the thin threads, 2 monofilament strings attached to the vertical arm for monthly checkup. We have the Mirena, which releases 20 micrograms per day, and the efficacy lasts for 5 years. Skyla is not freely available in India, and it is much smaller, and the release rate is 14 microgram per day, and it lasts for 3 years. It's very popular in the Western countries. And we also know that it thins the endometrium, and endometrial concentration is 1,000 times more with levonorgestrel IUD. And the most important thing is, unlike combined contraceptive pills, the cycles are ovulatory. Pregnancy rate is 0.1 to 0.2%. So it's really very, very effective. It has its own adverse effects. Irregular bleeding can be common in the initial 3 to 4 months of use. So proper counseling really goes a long way. So the prolonged bleeding can be there, which can be treated. Unscheduled bleeding, which is not liked by our Indian women because they cannot go to temples. So we have to tell them this is not periods at all. So probably you need not consider it as periods. And later they go in for amenorrhea and spotting at the end of the 1 year. So this amenorrhea also counseling should be done. Some women are very happy. 25% of users will become amenorrheic after the 2nd year of use. So, counseling really plays a vital role. So, it's very important to stress on the non-contraceptive benefits too. Improvement in dysmenorrhea. So, copper T causes dysmenorrhea, but then LNG IUS really improves dysmenorrhea, and it is used for treatment of heavy menstrual bleeding. Anemia also improves because bleeding becomes less. Improvement in endometriosis-related pain reduces the risk of endometrial hypercarcinoma by having a beneficial effect on endometrial hyperplasia and reduction of PID. But there are certain contraindications too. Generally for IUDs, current STI, PIDs, post-septic abortion, malignant trophoblastic disease, unexplained vaginal bleed, endometrial and cervical carcinoma, fibroids with distortion of uterine cavity. So any uterine cavity distortion, you cannot use both IUDs. In copper allergy, probably we can use LNG IUS. We have certain conditions where they can be used, like when patients are on anticoagulant or who have bleeding diathesis, LNG IUS is really very safe. And in immunocompromised HIV patients also, it can be used in conjunction with condom. On cancer chemotherapy and transplant recipients, nulliparous, it can be used with good efficacy. And prior thromboembolic events also, although it is hormonal, it is category 2. That means benefits outweigh risks for DVT and pulmonary embolism. But then it is category 3 for prior ischemic heart disease. So among breastfeeding women, we know copper T is really helpful, but even for other women, for breastfeeding women, LNG IUS can be used. So less than 48 hours postpartum, it can be used just like copper T. 48 to 4 weeks, we will not be using. Then more than 4 weeks postpartum, it can be used. In puerperal sepsis, of course, all intra-uterine devices are category 4. So earlier, we have, in 2010, IUD in HIV infection was a big no-no. But then we understand now that in women who are high risk for HIV, that is with high risk behavior, or even HIV infection, or in AIDS, or patients who are on ARV therapy, it can be used. But then copper IUD will not be inserted for the first time for AIDS, but if it is already there, it can be continued. So we talked about copper T, then we talked about LNG IUS. So we know that the unmet need is huge, and even in Tamil Nadu, we see that contraception uptake is not up to the mark. So the government of India has really given a basket of choices for our women. So we have the Antara, the free injectable contraceptive, and Tamil Nadu government launched it on September 14, 2017. So this is depomedroxyprogesterone acetate, a microcrystalline suspension 3 monthly. We also have a subcutaneous DMPA, which is available, Cyanapress, but this contains less DMPA, 104 milligram every 3 months. The norethistérone enanthate injection, which can be given every 2 months, is not available in India. So the ideal use failure rate is 0.3%, and the typical use failure rate is about 3%. So here also, here ovulation is suppressed and there is thickening of cervical mucus. So I told you about the Antara, which is in government sector, and the Depo-Provera, which is available in the private sector, and the Cyanapress, which is 104 milligram. So inhibition of ovulation, thickening of cervical mucus, and thinning of endometrium. It is a safe, highly effective with long-term contraceptive benefits, convenient, easy to use. It is given every 3 months with the grace period of 2 weeks. But the only big thing is that it is reversible within 7 to 10 months from date of last injection. So patients, unless counseled, are a bit worried. So pelvic examination is not required prior to use. Dr. Shobha Gudi said that for many contraception, for many contraceptives, we need not have any preliminary investigations. And for women who are ineligible to use estrogen-containing contraceptive, it is ideal, suitable for breastfeeding women after 6 weeks, and may be used by any women or any woman at any age of parity if they are at risk of pregnancy. But then we have to stress on the non-contraceptive benefits of DMPA. So like LNG-IUS, it decreases menstrual cramps and reduces premenstrual syndrome. And it also improves anemia by reducing menstrual blood loss due to menstrual changes such as amenorrhea, reduces the symptoms of endometriosis, decreases benign breast disease and ovarian cysts. This is very, very important. Helps prevent fibroids and reduces the incidence of symptomatic pelvic inflammatory disease. So women who are at risk for the above things or who are having these disorders, it would be an ideal contraceptive. It protects against ectopic pregnancy, minimal drug interactions. The risk of endometrial cancer is reduced by as much as 80%. The effect is long-term and increases with duration of use and possibly against ovarian cancer. And now we are starting to see a lot of sicklers too among our AN patients. That is because of the migration which is happening in India, and nearly 70% of reduction in the frequency of sickle cell crisis. This is a very important thing. But there are certain limitations too. It does not protect against STI, RT, and HIV infection. Once taken, the effect cannot be stopped immediately, and it causes changes in the menstrual cycle and bleeding. So this is really troublesome. They keep on having spotting, or sometimes they have profuse bleeding, and then sometimes amenorrhea too. So it's very, very important to counsel them properly. And there is decrease in bone mineral density, which is but transient. So we have to encourage calcium intake. Initially, there was a black box warning by FDA, but then that has been withdrawn. So generally for adolescents, it can be given for a minimum of 2 years. Mood swing and depression can be there, and weight gain about 2 kg in 1 year of use. So how to initiate injection DMPA? So in menstruating women, switching from non-hormonal method, within 7 days, no need for backup. But after 7 days, we need a backup method in the form of condom for 7 days from injection. And switching from a hormonal method also, postpartum feeding, the 6 weeks to 6 months, no backup is needed if exclusively breastfed, but they need backup if partially breastfed. And more than 6 months, it can be started at any time, but need backup for first 7 days. And postpartum who are not breastfeeding, less than 4 weeks, it can be started anytime, no need for a backup. But then more than 4 weeks, started anytime, but needs a backup. After miscarriage also, immediately after abortion, it can be taken. And after taking emergency pills also, same day as easy pills, this can be given. So that is very, very important. We have to keep on reiterating that emergency contraceptive pills are only easy pills are only for emergency contraception. So for definitive contraception, this can be used. And so every 3 months, it has to be given. And if more than 4 weeks, probably a backup has to be given. So coming to implants. So implants contain progestogen and they release the progestogen at a controlled rate. Failure rate is only 0.05%. Earlier, we had the Norplant 6 rods, which contains 6 rods. When as a junior assistant, we used to insert lot of Norplants. Then after that, that faded into obscurity, and Jadal is not available in India. And we have the Implanon. The Implanon, what is now available in India is Implanon NXT, which contains ethnogestrel for 3 years. We also have the biodegradable Capronon that does not require removal. See, in Norplant, the main problem was insertion was easy, but sometimes it would have migrated and removal was really problematic in a few. This can be overcome by using biodegradable, but it is not available in India. So Norplant, we all know it is not available now. And we have the Jadal abroad, which contains only 2 rods, and it contains 70 milligram of levonorgestrel in each rod, and it lasts for 5 years. It is easier to insert, so it's really a big welcome. But then Implanon NXT is available in India, non-biodegradable, a single rod, which contains 67 milligram of ethnogestrel, and single 40 millimeter rod, which is inserted straight from a sterile preloaded applicator, effective for 3 years. And unlike Implanon, Implanon NXT is radio opaque. It has about 15 milligram of barium, so it can be identified by taking an X-ray or CT. Low androgenic effect, good choice for adolescents, for women with hypertension, diabetes, anemia, and endometriosis. We already have choices for anemia and endometriosis and adolescent earlier. So even in women with high BP and diabetes, this Implanon NXT really helps. And actually, it is not freely available. In February, our Dr. Shobha Gudi conducted a program in Chennai and trained about 15 doctors in that. But then after that, it is not available right now in Chennai. But few use it in other cities elsewhere like Bengaluru and Hyderabad. So probably after this pandemic, they will start again. So the benefits are, especially it is good for women who have difficulty remembering to take the pill daily. So long-term contraception, really it helps, and rapid return of fertility after removal. But it has its own disadvantages, insertion and removal by trained personnel only. And the company itself, Organon, clearly states that this will be provided, implant will be provided only to people trained by them. It is more expensive, but not too expensive in sense. It costs about 2,000 rupees and odd. And for 3 years, I think it will be cost effective. So transient ovarian cysts in 10% of users, and breast tenderness, nausea, acne, and weight gain. Backup contraception needed for 7 days if inserted more than 5 days after LMP. So ideally to be inserted within 5 days. Removal, it is an office procedure under local anesthesia, and implant on NXT seems to be easier to remove. Fertility resumption is quite quick, and you can insert a new rod through the same incision and when you remove the old one. So that can be done. And for all these patients, I said that there can be troublesome unscheduled bleeding. So in those cases, what can we do? So RCOG 2009 guidelines state that we have to use a first-line COC for up to 3 months continuously or in the usual cyclical regime, but this is unlicensed. So better to use it continuously for about 3 months. And no evidence that reducing injection interval for DMPA improves bleeding. However, injection can be given up to 2 weeks early. Mefenamic acid, 500 milligram 3 times a day, can be used for women with bleeding on DMPA to reduce the duration of the bleeding interval, but no long-term benefit. There are a lot of confounders about LARC. So a lack of the medical officer herself is not very familiar, and there are a lot of misperceptions about the methods, high upfront cost. So because of that, initially itself, both the patient as well as the doctor do not take recourse to it. Lack of access to insertion services, healthcare providers' concerns about the safety of IUD use, especially in nulliparous, younger women and teenagers. So probably as gynecologists, we have to unlearn and relearn and understand that LARC is quite safe for nulliparous, younger women and teenagers. Patient barriers, including a general lack of awareness of LARC methods and information about their safety and efficacy. So it's very, very important that we lower unintended pregnancy rates, and that requires multiple approaches. Individual obstetrician gynecologists can contribute by increasing to LARC methods for their patients. So how do we increase LARC use? Counseling is a sheet anchor. We have to counsel all contraceptive options, even if patient initially states the preference for a specific contraceptive methods. We have to offer the basket of choices. We have to encourage implants and IUDs for all appropriate candidates, including nulliparous women and adolescents. Adopt same-day insertion procedures like see and treat. Whenever she walks in, we should be able to offer some form of contraception. So screening for chlamydia, gonorrhea, and cervical cancer is not required before implant or IUD insertion, but may be obtained on the day of insertion. Avoid unnecessary delays to initiate a method, especially see after miscarriage. We need not ask them to come for follow-up visit and then start. Sometimes they may not turn up also. So it's very important to try to utilize the visits and start contraception immediately. So we should know that they are more than 99% effective, 100% reversible. That is very, very important, especially for our setup, where young women opt for sterilization quite early, and rate of discontinuation is quite high, about 10%, and risk of serious complication with an IUD is less than 1%, and risk of perforation from an IUD is less than 1 in 1,000. So it's very important to counsel our women so that they take recourse to LARC, so that we do not have any with different methods. We have varied rates of unintended pregnancy. So for implant on NXT, it's only about 0.05. For hormonal IUD, 0.2 to 0.9. For copper IUD, 0.8. For Depo-Provera, 6. And for pill, patch, and ring, it is about 9. So we should think about all these things before encouraging our women to take up LAR. And also, see, 6 months discontinuation is quite high for DMP. But then now we have found out that especially in Tamil Nadu PSCs, the take-up of Antara is really very, very good, because patients have been counseled well, especially the VHLs, they know and they follow up the patient. So the discontinuation rate is really very less now with DMPA. And Dr. Shobha Gudi also talked about the medical eligibility criteria for contraceptive eligibility. So if it is 1 or 2, it is ideal. 1 is no restriction of use, and 2 is when advantages outweigh the risk. So all of us should have this ready reckoner with us. So no point in actually trying to remember everything. And one thing what we should know is this copper IUD is really, that can be prescribed for nearly all conditions. So that can be a problem, especially in cervical cancer awaiting treatment. But then for initiation only, it cannot be done, as Dr. Shobha Gudi also pointed out. But then if she is already having one, she can continue till her treatment. So if you use copper IUD, generally, no problem at all. But then for anatomic abnormalities, where the uterine cavity is distorted, any IUD cannot be used. So for anemias, all thalassemia, sickle cell disease, all these things, all can be used. Copper IUD probably less preferred, but then still it is category 2 because it can cause bleeding. And benign ovarian tumors, then breast disease also, it can be used. But then what is important is if she's having current breast disease, only when she has current breast disease, then these hormonal methods like Depo-Provera, implant, and LNG IUD cannot be used at all. I already talked about cervical cancer. For all other cervical problems, all these can be used. Cirrhosis also, better to avoid hormones. So it is category 3. So here a copper IUD can be used. And when we
Sorry
have
to interrupt. Can we wind up, ma'am? Because next.
Yeah. In depression also it can be used. And for endometrial cancer, probably for initiation it is difficult. For gestational trophoblastic disease also, it can be a problem. For all hyperlipidemias, hypertension, inflammatory bowel diseases, it can be used. So anybody less than 20 years for adolescents, which we think we cannot use, this can be used. So this is a paper published in IJOG, which talks that more than, although use of LARC methods is increasing, it remains underutilized. And we have a contraceptive choice project in US where all these LARC methods were offered free of cost, and then the uptake was really good. So to conclude, LARCs are long-acting, reversible, and highly effective contraceptive methods. They include IUDs, both copper and hormonal, DMPA, and contraceptive implants. Initial cost is high, but ultimately it is economical. And DMPA and LNG IUD offer non-contraceptive benefits to women, patients with heavy menstrual bleeding and endometrial hyperplasia. Copper IUD can invariably be used in all situations. Even in non-compliant women, IUD and Implanon can reap contraceptive benefits. I thank you very much for the opportunity and for the patient hearing. Thank you very much.
Thank you, madam, for this elaborate and exhaustive talk on LARC. And like madam said, LARC is very important because it has 3 important things. It's a one-time contraception. It is reversible, very highly efficacious, and not having much side effects. But I would just like to stress on two important things, especially nowadays we see more and more patients coming with either getting themselves, married again or divorced and wanting another child. So like Madam said, in these younger individuals, we should think twice before having a permanent sterilization. In such case, I think LARC would really be very, very useful because they always have the option of having another child instead of going in for recanalization. That is one. And awareness of LARC, because it is so efficient. I think all of us should promote LARC because there are so many advantages. Proper counseling is very, very important, and we should go by all the strategies that Madam said and try to improve LARC awareness and encourage many patients to use LARC. So I think that finishes it. And I would really like to thank Dr. Deepa and Dr. Malati for having given me this opportunity. Thank you so much, Dr. Deepa and Malati. It was a wonderful. Looking forward to the skit and all the video competitions. Nice, different way of celebrating this population day. Thank you.
Thank you so much, ma'am. Thank you so much, Dr. Shanti. That was a beautiful, elaborate talk. I think we'll reserve questions for the end of the session because the next speaker is waiting. Thank you, Dr. Chitra, for comprehensively summarizing what Madam said and for your inputs. Thanks so much for being with us. We now move on to the next session. Let me invite the next chairperson, Dr. Radha Madhavi. Dr. Radha Madhavi is a very, very dynamic president of Tiruvannamalai OG Society. She is a director, Rajam Multi-Speciality Hospital and Rajam Institute of Paramedical Sciences. She is an MD DNB and has done senior residency at Kidwai Memorial Institute of Oncology. And she has conducted annual conferences and very enthusiastic and dynamic president. Please welcome Dr. Radha Madhavi. I request you to take chair and introduce the next speaker for the day. Can we stop sharing the slide? Julius?
Yes. Can you hear me?
Yes, Dr. Radha.
Good evening. Thank you very much. Thank you to Dr. Deepa and Dr. Malati for giving me this opportunity. It is my privilege and honor to introduce Dr. Atul Ganatra, who is Vice President FOXY 2021. We know 2021 was a great year for all of us. And Joint Secretary IAGE, Chairperson MTP Committee MOGS 2012-2014, Managing Committee Member MOGS, Medical Advisory Committee Family Planning Association of India, Director RJ Ganatra Nursing Home and Progeny IVF Center Mumbai, Consulting Obstetrician and Gynecologist, Gynecological Endoscopist, Fortis HMN Jupiter Hospital Mumbai, and he is very interested in women's health and he's worked for 3 decades in the upliftment of women's health. He was the right-hand man to our past president, Dr. Alpesh Gandhi. Sir, I hand over the dais to you to enlighten us on the updates of tubal sterilization.
Thank you, Radha. I'm not going to call you Dr. Radha Madhavi. I've known Radha for almost 30 years and I was present for her wedding. Radha's husband happens to be my first roommate and classmate. Radha has now become the president. Difficult to be the last batsman in such an extensive inning that has been played. Thank you very much, Dr. Malati, Dr. Deepa, and Dr. Shobha Gudi for this opportunity. I think Tamil Nadu and Karnataka are homes for me. Na koncha Tamil pesare. So I can speak a little bit of Tamil. Can I share my screen now? I hope my slides are seen.
Yes.
Radha Madhavi, my wife is also Madhavi and she says hi to you.
Thank you, Madhavi. How are your children too?
Well, thank you. So either we reduce the world's population voluntarily or nature will do this for us, but brutal. And I think the pandemic has taught us that very well, as to unless we look after our health, unless we reduce our comorbidities, and unless we look after our parents, friends, our staff members, and our children, we know what the pandemic can do to all of us. And happy to share that finally, after a lot of lobbying with the government, the vaccination has been approved for pregnant women in our country. we did have to work very, very hard on this. And I would thank all my vice presidents. I think Dr. Ramani Devi is also here. We did actually have to do a lot of lobbying with the government and the ICMR. This is a very interesting article, Early Impacts of the COVID-19 Pandemic, Findings from 2000 Good Marker Survey of Reproductive Health Experiences. And I would request all those who are interested in SRH services to kind of read this article. We know the pandemic did deny a lot of our women contraceptive facilities. And I think Dr. Shobha Goody and the entire Health and Family Welfare Government of India did a lot of hard work in promoting, and not only promoting, lobbying to make safe abortion and contraception a part of essential services. There was a time when we used to get telephone calls to say that my property removal is due and I cannot find a transport during the lockdown. There were times when the Deepa injection was not available and the government set up IUCDs were, kind of some was in scarcity. So that was a very, very difficult situation during the complete lockdown. And that did have a lot of patients with unintended pregnancies. I'm going to stick to my talk now. Vision Family Planning 2020 for India is not just about providing contraceptive services to an additional 48 million women, but aversion of 23.9 million births, 1 million infant deaths, and over 42,000 maternal deaths by 2020. This was the goal of the Family Welfare and the Government of India, the Health Minister's goal, and the goal for the SDG. Reaching 48 million additional users is not a target, but a benchmark of progress towards commitment, a commitment to enable users to choose and plan their healthy and reproductive life. And today we are in a situation where we can choose your mobile phones, your cars, your houses, your clothes, but you did not have a right to choose your contraception and method of sterilization. Because we know even today, the kind of contraception services that are provided, at least in the periphery, are either controlled by the husband or controlled by the mother-in-law or members of the family. And this is this clinical situation of ours, the population share of major countries, and we know we contribute to a good 17.5%. We have a long way to go as far as contraception is concerned. And today, my topic is going to be on updates of tubal sterilization. I think there was a time in 1994 when I used to do about 40 lap TLs, laparoscopic sterilization, in a day in a camp setting, where the mode of surgical procedure was local and vocal. Local injection pethidine was given 100 milligrams intramuscular, and then we would do the lap TL and the local. And such was the bearing capacity of these women that they would go home before I went home. But times are different. Times have changed. We know female sterilization is the most popular, highly effective, and a safe permanent method. 4.1 million female sterilizations were done in 2013-14. The total unmet need for contraception is 21.3, mainly due to lack of skilled service providers at peripheral health facilities. We are not able to achieve this target. I know of a very dear friend, Kalpana Apte, who happens to be the director of FPI, telling me that if there is anybody who is willing to go to Northeast or towards the Dibrugarh and Calcutta side, we will pay them whatever they want to do lab TLs. I happen to be a member of the medical advisory committee of the FPI as well. And we are doing our best to send skilled providers to these peripheral locations where the lab TL facilities can be provided. And unfortunately, because of the pandemic, lab TLs in camp settings came to a complete halt. The NHM Government of India strengthened health facilities for providing assured fixed-day family planning services at many SDs, FRUs, CHCs, and even PHCs. I have physically done many lab TLs camps for over the first 3 to 4 years of my practice, where we did, like I told you, about 40 to 50 lab TLs. Let's talk about the history of ligation. Bludel in 1823 suggested ligation, Madlenda in 1999, Irving in 1924, Pomera in 1930, and we know these are different types of open tubal sterilizations, or what we call as mini lap. Uchida in 1940, Bosch in 1936, first lap ligation in Switzerland with electrocoagulation. In November 2002, the FDA approved the Assure for hysteroscopic procedures. I work at a tertiary hospital and hence get very complicated cases for lap sterilization sometimes. And the most common being previous 2 and 3 and 4 cesarean sections, which is not uncommon, or patients with medical conditions. But we don't seem to understand that, like what Dr. Shanti said in an excellent exhaustive lecture, that we should offer the lab facilities to our patients. I think, of course, it is our goal that we hand over a basket of choices to our patients and let them decide what mode of contraception should be followed. But unfortunately, in our country, even today, tubal ligation and sterilization is probably the number one on the list. I was very lucky to be a part of this ICOG Foxy Good Clinical Practice Guideline of female sterilization, where my dear friend Mandakini Parihar, who's no more, and she will always be remembered, where we made the first guideline for female sterilization and recommended to the government. Today, this guideline is followed extensively, even today, in the Ministry of Health. Some bad newspaper headlines like this one, as you can see, 11 women died after undergoing sterilization surgery at a health camp in a state in Chhattisgarh. But they did not die of a surgical complication. They actually died of a drug reaction. So, unfortunately, headlines like this really take away our women from undergoing lab sterilization. And this is not what is really needed today. It is estimated that 37% of all married women in India are sterilized. In 2011-12 alone, the government of India said 4.6 million women had undergone a tubectomy. Whether it's open tubectomy or a lap TL is not clearly mentioned there. Types of tubectomies, we know. I don't think I want to go into the surgical details. I probably want to bring out some salient features. We know initially we did mini laps where we tied the tubes. I've had a couple of failures, maybe one failure when we were initially using linen to do our mini laps, and then we gradually switched over to just chroming catgut. It could be banded, it could be cauterized, as I told you in the history. Now, of course, the most famous procedure or the most accepted procedure, at least in the metropolitan cities, is the tubal sterilization. Unfortunately, rules are very stringent to do a lab sterilization in a patient with a previous surgery or in a postpartum period, and we'll talk about it as we go in. It's okay to do a hysterectomy in a 4 previous cesarean section, but it's difficult to do a lap tear in these situations, which is something that I fail to understand. I think it is up to the expertise of the operating surgeon to be able to decide what kind of surgery or what kind of family planning procedure should be undergone. So I am going to today talk about some standards of female sterilization. This is from the Ministry of Health, published in 2006. And I think today we are in a medical legal world where we need to follow this verbatim. I know what I can do, but I need to know what I can do. Most important of the eligibility for the providers, mini lab services, trained MBBS doctor can do it, but a lab sterilization can be done only by an MD. Or DG or an MD or an MS in surgery trained in laparoscopic sterilization. And this is, I think, a requirement. I was not aware for many years that we needed a certificate like this, at least in Maharashtra, to perform laparoscopic sterilizations. Unfortunately, I'm sorry, the quality is not very good. And you also need to have an assistant with a similar certificate who will assist you in the surgery to perform a lab sterilization. So this is something, by virtue of our degree and training, we are allowed to do lab sterilization, but in Maharashtra, there is some new GR which has come in, which requires this kind of a certificate. Physical requirements for female sterilizations are extensive, the kind of equipment that you need, the kind of OT setup that you need. I don't think I can spend a lot of time talking about it, but I think a decent operative theater where obstetric surgeries can be done is pretty good to do a lab sterilization, mini lab sterilization. Laparoscopy, of course, needs. We need to remember that we need to go through these guidelines. We will be talking about a few of them. So case selection, I think this is the most important part. The client should be married, including what is said as ever married, should be below the age of 49 and above the age of 22. Now, this is a catch here because in the past, I have done lap TLs on patients who are less than 22 and had 3 children. So this is a Government of India guideline and we probably need to follow this. The couple should have at least one child whose age is above 1 year unless the sterilization is medically indicated. Clients or their spouses, partners must not have undergone sterilization in the past. Clients must be in a sound state of mind so as to understand the full implications of sterilization. Mentally ill clients must be certified by a psychiatrist, and a statement should be given by the legal guardian, spouse, regarding the soundness of the client's state of mind. Clinical process, of course, preoperative checkup, preoperative instruction, explain the surgery. And I think now, today, we are in an era of audiovisual aids where we can actually have most of our surgeries on our mobile phone or on our desktop so that we can show it to our patients how the surgery is done. So I think explaining the operation is extremely important. And we need to have adequate postoperative counseling, voluntary consent, and fitness of the patient is absolutely necessary. This is important that we do a thorough physical examination of the patient and at least put our stethoscope on the chest of the patient to see that the patient does not have a cardiac problem. Just 3 days ago, I came across a patient who was advised an open hysterectomy, and she came to me for a second opinion. And I thought that the patient only needed a LNG intra-uterine device because her only complaint was abnormal uterine bleeding. But when I put my hand, stethoscope on the chest, I found out that she had a murmur with mitral stenosis. So that is a very, very important part. So here, if this patient had undergone, and she had already been given a time of admission of that evening for surgery. So I think this is very important. We must, even today, after about 30 years of my practice, I still record my own blood pressure and put a stethoscope on the chest of every patient I see. I think that is something that we need to remember. Counseling, they must be informed of all the available methods of family planning, preferably in a visual chart, and should be made aware that all practical purposes, this is a permanent operation. They must be informed to make of course, they must make an informed decision. They must be counseled whenever required in the language they understand. The client should be made to understand what will happen before, during, and after surgery, its effects and potential complications. Even today, 1 on 10 patients, when I'm counseling them for a lap hysterectomy, because we are a referral center for lap hysterectomy, ask me, will I get periods after a hysterectomy? So they really don't know, and we need to tell them very, very clearly. So ideally, show them the procedure. So the following features of sterilization procedure must be explained. It is permanent procedure. It can be reversed, but it is an extensive surgery. It can have failures. It does not affect sexual pleasure or ability or performance. It will not affect the client's ability to perform day-to-day functions. It does not protect against RTI, STI, or HIV and AIDS. The client must be told that a reversal of this surgery is possible, but that the reversal involves a major surgery and its success cannot be guaranteed. Must be encouraged to ask questions or doubts if they have any. And the clients must be told that they have the option of deciding against the procedure anytime before they are taken into the theater. And we must know that this patient is not undergoing this procedure under any form of stress. Assessment of the patient, I cannot discuss this enough. Remember that if you could have any other death and as a result of an obstetric or a gynec complication, but if you have a tubal ligation death, it goes straight to the state government and you could be called for an explanation, and we will tell you why. Timing of the surgical procedure, interval sterilization should be performed within 7 days of menstrual cycle, postpartum sterilization within 24 hours or up to 7 days. Sterilization and medical termination of pregnancy can be performed concurrently. Sterilization procedure following a spontaneous abortion can be provided, provided the client fulfills the medical eligibility criteria. This is something that I don't agree. Laparoscopic tubal ligation should not be done concurrently with the second trimester abortion and in the postpartum period. Now, second trimester abortion could even be 14 weeks. And I don't see any reason why a lap TL cannot be done. I mean, if I can operate on a patient with a 20 weeks uterus and do a lap hysterectomy, why can't I do a lap TL of this patient? But this is the government rule, and we don't question government rules. And even in the postpartum period. Informed consent, of course, has to be taken. And here again, consent of the spouse is not required for sterilization. So because if a man wants to undergo a vasectomy, he need not have a consent of the spouse, but you can take an anesthesia consent just to be on the safe side. So please write bilateral tubal sterilization on the discharge card. I have seen people go to court because they have written tubal sterilization and the word bilateral was not written, and the patient had a failure of tubal sterilization. Mention the follow-up date after 7 days in case of MTP lap TL. Mention report to the hospital if the patient does not get period within a month after a MTP lap TL. Keep a copy of the discharge card in the indoor case paper. An Aadhaar card copy of all indoor patients. Now, it is not mandatory for MTP or for lap TL to take a documented evidence, and the MTP chair is there on the days right now. But what we do is we take an Aadhaar card copy for all our OPD and indoor patients. We take a snapshot as a identity proof for all patients. So that it includes, if we go to a hotel reception, don't they ask us for a photo ID? Everybody is asked for a photo ID. So you cannot take it's not mandatory to take age proof from all patients, but for our safety, if we take it for all OPD and indoor patients, the question does not arise. So this is a smart way of kind of escaping or, being with the law. Complications of lab sterilization can be many: nausea, vomiting, vasovagal attack, respiratory depression, cardiorespiratory arrest, perforation. I've seen many perforations in the camp setting because dyes used to put and nurses used to put the manipulator, and they did not know what was anteverted and retroverted uterus. And every retroverted uterus in the camp setting was perforated because they only put the manipulator assuming that the uterus is anteverted. Bleeding from mesosalpinx, a tear can occur, so you must have a bipolar cautery available with you. God forbid there is a problem. Bladder has to be emptied. I think this is very important. I have seen in a camp setting when an international faculty was operating, about to do a lap myomectomy, and when he put in the trocar was in the stomach. So an Ryle's tube, of course, in a lap hysterectomy, not for a lap TL. So injury to the bladder is extremely important. Injury to the intra-abdominal viscera in cases of previous cesarean or tubal cox. So history taking is very important. Convulsions and toxic reactions can take place, as we saw in the Chhattisgarh episode. Wound sepsis, we'll talk about what sterilization should be done. Hematoma in the abdominal wall, intestinal obstruction, paralytic iris, peritonitis, tetanus, incisional hernias, of course. So that's why I think before we take up any patient for surgery, a proper look at the abdominal wall of the patient is extremely important, because we don't see the entire abdomen and perineum. So often we come across patients with fungal infections, and we realize them on table when they are in the lithotomy position that the patient has a fungal infection. So failure of the operation leading to a pregnancy, this should be there in your consent form. The patient has to understand this, and all cases of failure and complications, major or minor, arising during pregnancy, during surgery or post-surgery, must be documented. This complication that required hospitalization and all cases of failure must be reported to the district health authority, and I'll tell you why. You must explain to the patient that sometimes there can be transient menstrual irregularities and they are not related to sterilization. Evaluate for chronic infection in these patients. Psychological problems, example, depression, more common with the LARC methods, as Dr. Shanti said, but can occur in these patients as well. How do we sterilize this equipment? We've had a couple of patients of atypical mycobacteria with our operative laparoscopy patients, and that is why we do not use anything which is not autoclaved. If possible, please develop your institute into a situation where you autoclave everything. At our institute, we do not put anything in Sidex except for our telescope. If the telescope is to be put in Sidex, it has to be in Sidex for at least 4 hours if you want high-level disinfection. Sterilization by chemical method, you can put it in 2% glutaraldehyde, but glutaraldehyde stains your trocar cannulas and your band applicators, and that's why I don't like glutaraldehyde. But I think nothing to beat autoclave. These instruments are not very expensive, and you can just put them in a simple peel pouch or wrap them in a towel and put it in your autoclave drum. Steam sterilization is what we do for all our instruments, timing 20 minutes for unwrapped and 30 minutes for wrapped instruments. Gloves, of course, we have to use disposable gloves. Temperature 121 degrees, pressure 15, and sterilized packs can be used for up to 1 week if kept dry. So we use only peel pouches. We don't use drums, or instruments are not put in green towels, drums, because sometimes they can be wet when they come out of the drum, no matter how much care you take. Processing of the laparoscopes, of course, I said 4 hours of Sidex or glutaraldehyde, that is very, very important. And of course, we must clean the laparoscope thoroughly. A lot of our problems with atypical mycobacteria came because we were using tap water to clean our telescopes, and the wet telescope was being put in Sidex, and we were taking them out in less than 4 hours. And that is when we found out from a study in Hinduja Hospital in Mumbai that the tap water had the atypical mycobacteria. And that is why the final cleaning has to be done with either saline or distilled water, or you should wipe your instrument dry before it goes into the Sidex. Now, of course, we don't use Sidex at all. A final certificate is to be given to the patient as to what anesthesia was given, timing of the procedure, technique that is done, whether it's mini lap or a lap TL, method of occlusion of the tube, whether a band was applied or a Filchie clip, and details of gas insufflation, of course, have to be mentioned. Insufflator utilized, what was used, CO2 or air, specify details and complications and management. Sometimes you come across suddenly a patient with a unicornuate uterus. Today, please remember that any unusual finding on table and that you are not recording with a recording device, you have your mobile phone with you. Instantly record that on your mobile phone and send a WhatsApp of that particular video to the patient and tell the patient to save it. Or you can even give them a printout. So that is not difficult because you may not remember this case 6 months down the line. So I think that mobile phone should be used extensively. Post-operative information, when did the patient pass urine, distension, patient feeling unwell. We must tell our patients that they will get kind of shoulder pain after CO2 is used in a lab sterilization, so that they don't worry, because suddenly they will come across and say, I have a lot of shoulder pain. And this is the kind of consent form that we have, which is approved by the government of Maharashtra in multiple languages. In front it is in English and behind it is in Hindi and Marathi, which includes the fact that there can be a perforation also and an injury to the bowel. You can see here, I don't know if it's clear, I have been made aware that I can have the following complications. And I always write bowel injury in this, or a trocar injury, or an injury with my Verries needle. So this is something that we must follow. You cannot have any form. There is a government approved form for mini lab and tubal sterilization, which has to be followed. And I'm sure Dr. Shobha Guri will have them sent to you. And this is why I tell you that a complication has to be reported, because there is a manual of family planning insurance scheme, at least in Maharashtra, but I think this is a national thing, to be operated by the Oriental Insurance Company. 1 lakh rupees for death, tubal death, 30,000 rupees for death within 30 days, 20,000 rupees for failure, and 20,000 rupees for medical complications. So I think this is something that is very, very important, and we must know. In fact, we are supposed to pay the patient to do a lab TL. A doctor also is supposed to get 155 rupees for every lab sterilization, but I think that money hardly comes. And finally, friends, if the world is to save any part of its resources for future, it must reduce not only consumption, but also the number of its consumers. And that is why I think family planning is an extremely important subject, and all of us must spend enough time with our patients to convince them for some form of family planning, which could be just a barrier contraception, LARC methods, OC pills, or even lab sterilization. Thank you very much, and I hope I have not discussed the surgical aspect a lot, but I think surgical aspect is very, very simple. We all are experts at doing lab TLs and lab sterilizations. Some of the legal aspects is what we need to remember and understand. Thank you very much for this opportunity.
Thank you, Dr.
Radha Atul.
Thank
No,
you,
Dr.
Dr.
Atul.
Atul. Okay, Atul, so nice that I'm seeing you after such a long time on the virtual platform. Sometimes you come down to my place with Madhvi, of course, and it was such an elaborate talk, and your talk shows your love for this subject. And it's very nice that you're so much interested in women's health, and hopefully one day you will see that the ratio of male sterilization and female sterilization is equal in this country. Thank you.
I wish I was given the male sterilization topic. I would have spoken more about it.
Thank you.
Next
Thank you
time,
so
Atul, I will take you up on that, and that is for next time.
Shobha ma'am, why we should represent male sterilization more, I guess.
We shall do that. Please help me, Madhavi. In
I will have an emergency
I am
on that
doing.
day.
Thank you so much. Thank you, sir. Thank you, sir.
Thank you, Atul, for
Thank
honoring the invite and being here. And Deepa, if I may say, Radha, if I may say a few words. Is it okay? Yeah.
Sure, ma'am. Sure,
So,
ma'am.
last year was fantastic because I got such a wonderful president to work with. And I have two vice presidents here from last year, and I must say that it was a delight because both of them were so very supportive for chairpersons. I don't think Dr. Ramani is paying attention. So you're muted.
Yes.
So Dr. Atul, thank you very much for supporting the committee work. And there was always support and only support and encouragement, never a word of dissent. And his trust in us was so absolute. And he never questioned, our programs, but only had additions and value add-ons. And of course, the most important factor was his presence as faculty. And that is so very cherished because he's such a wonderful speaker. I've always admired the way he delivers his content. And thank you very much, Atul, for everything that you have done for us. Thank you.
Thank you. Thank you.
Thank you, Dr.
MTP
Ramani.
and contraception comes from
Thank
straight
you.
from the heart.
Yeah, that is right.
Nice to see you. Nice to see you.
Thank you. Yeah, Dr. Ramdev.
Thank
you,
thank
Dr.
you so
Deepa.
much. Thank you so much, Dr. Atul, for taking time off to be with us today. I think he's a real gentleman. I've seen him talk and I've interacted with him quite a bit. Thank you, Dr. Radha, for nicely chairing that session. You should give it to me for connecting you both together today. I was in fact just thinking that I must have Radha sometime as chairperson, and Dr. Atul just messaged that she happens to be his classmates. So I was like on cloud nine. I said, okay, let them meet on this platform. So
Atul speaks all the three languages of the South.
Oh, that's very nice.
Deepa Channa Kannadanu matartare.
Kannada also. Okay.
Kannada also.
Very nice. Incidentally, I think he's had some casualties in his clinic during this Mumbai rains, and he has joined us despite all the odds at his place. I think it's been a real pleasure having you today, sir. Wonderful. That was a wonderful talk. And I think all the three talks for today were exhaustive, wonderful, and absolutely informative. I think I'm very happy for having such faculty for today. Shobha ma'am, can we go ahead with the next session of video and skit presentation? I think there are no questions. I think all the three talks have been really elaborate, and so I think there are no questions. Let us wait for the skit and video presentation now.
Thank you. I'm going to take
Thank you
leave.
so
Sorry.
much.
Yeah, thank you.
Thank you. Thank you so much, sir. Thank you.
You're a gem. Thank you.
Thank you so much, ma'am. I think I must give it to you for making this day very lively. We were just thinking of some nice topics and some enlightening things, and you have really spiced up today's program by suggesting the right people and also including this skit and video competition. I think we really enjoyed watching everything. I understand a little bit of Hindi, so I could just follow. I really appreciate. First of all, congratulations to all the participants because the participation is important. Winning is not important. In fact, taking the time off and doing this for us itself is a big thing. I really enjoyed watching everything, and thanks so much to judges, Dr. Ramani madam and Dr. Shanti madam for their presence and for their effort in judging these people. Last but not the least, thank you all the delegates. I think the speakers have left, but I still owe them a lot. Dr. Atul, Dr. The chairpersons also, Dr. Radha Madhavi, Dr. Chitra, they are not here, but still my sincere thanks to all the faculty, all the speakers and chairpersons for making it a very, very nice evening today with a lot of take-home messages for the delegates. I really thank Abbott for initiating this webinar today and for supporting us. I really thank Julius of Kathy and Riti Systems for giving us this platform. And I must thank the delegates. We had at least 70 of them participating today. I think on a weekday, I think Tamil Nadu has opened up now after the lockdown, and so people are getting busy. So on a weekday at this time of the hour, 70 people have logged in. It's really very nice that all of them had logged in. And thank you so much, delegates. We should call it a day. I'm really glad and proud that we had such a wonderful webinar today. Thank you so much. And I think I must thank Shobha ma'am, your compeers also. They have done a wonderful
They
job.
have to.
Yeah. Thank you so much. Looking forward to many more programs with you all in future for Trichy.
And Rajal, हम आपके orchard में